ladies and gentlemen, and a very warm welcome to this instruction course on the disturbed capsule managing the consequences. First of all, I would like to invite my faculty onto the stage, Dr. J.K. Reddy, Dr. Chandrakant sir, Dr. Mridula, Dr. Jay Prasad, Dr. Jason. I would like to invite the other moderators, my co-moderators, Dr. Anthrios, Dr. Krishna Prasad. I don't know whether they are here. So as ECC surgeons, whether it is SICS or FACO, our focus is always on trying to safeguard the integrity of the capsular bag, whether it's the anterior capsule, the zonules, or the posterior capsule. In fact, our whole focus is to preserve this flimsy little structure, very flimsy and delicate structure. In fact, throughout our whole lives as surgeons, that is our whole focus, to avoid damage to those structures. In fact, we are so focused onto that many times we, especially in the beginners, residents, they completely forget about the corneal endothelium. If you see, look at the incidence of striate keratopathy post-op, it's much, much higher than posterior capsular end. But anyway, that is a different story. It's not part of this instruction course. So in this course, we have a very senior and eminent panel of very experienced phaco surgeons who will share their experiences regarding their misadventures with the capsular bag and how best they were able to manage it. So starting with the anterior capsule, we have Dr. Chandrakant sir, who will be speaking on the capsular axis tear, how to go about it. Dr. Chandrakant is, as you all know, the chairman of the organizing committee of this very wonderful Drishti 2022. He's a very, very senior phaco surgeon, a very master clinician, as well as a very able administrator. So we are fortunate to have him here. Over to Dr. Chandrakant.
Good morning, everyone. Dr. Anup, chairperson, Dr. Jay Prasad, Dr. J.K. Reddy, and Dr. Mridula. The topic given is Rexis tear, how to proceed further. Throwing in light to the things which we have to take care before the tear happens. There are certain conditions wherein we should expect Rexis tear to happen. This could be a proper pre-operative assessment. Which are the cases which we expect to have this Rexis tear? The hypermature cataracts, Morganian ones, and lots of fluid inside the capsular bag, and even the hypermature cataracts which are sunken fluid inside the capsular bag, you can see there are folds in the anterior capsule. These are the cases which we should we should care more while doing a capsular rexis. Fine, now the rexis tear has happened. How to manage? I got 3 case scenarios to present. This is a soft cataract, it's a mature cataract. Yeah. You're doing a rexis, you have to put a methylene blue, then you have washed it out. Rexis is in progress now, you can see that. Tries to go to the periphery, the rexis margin tries to go to the periphery. See there. The trick is release the chamber pressure. Still, it has gone out. I'm using a micro rexis forceps to retrieve the anticapsular tag. Then use this curved venas. Then finally I finish it. Then it comes a routine thing. Then go for a normal phaco emulsification. Phaco chopping in progress. Emulsify Good job. Now emulsify the nucleus bits. Last piece is being emulsified. Take care of the corneal endothelium. Use lots of viscoelastics. See that the anterior chamber is formally formed. Finally, the intraocular lens is implanted. Come to case 2. A major cataract again. Rexis is in progress. Round, curvilinear. But there's a small break there in the anterior capsule. Somehow retrieved it. See that the antechamber is well formed before you do these procedures. See, it tries to go to the periphery. Then use the bent Vanna scissor to cut it and retrieve it. Slowly do a hydrodissection. Then usual conquering, you cut it, fake emulsify, chop it, fake emulsify the nucleus bits. Take care of the corneal endothelium, use viscoelastic substance on and off to form the antechamber well. Last bit is being emulsified. The epinucleus. Then the IOL is implanted. Come to the third case scenario. Again, a mature cataract. You've been doing a small mini rexis. Then release the loose cortex, release the intraventricular pressure, wash away the loose cortex, then make a small nick on anterior capsule. Using a bent Vanna scissor, make a small nick there, then proceed with a micro rexis forceps. Your hand movements should be very slow. All these procedures should be done with a good antechamber formed antechamber. Here, I bring the nucleus outside because it's a soft nucleus, because there was a PC rent in this case. But in spite of that, with a soft cataract, we can keep the nucleus in the antechamber and still proceed with the phacoemulsification. You can see the small rent there. Here you can see that. But in spite of that, the cataract was removed and the IOL is implanted. The take-home message is, whenever you see this the rexis margin goes out, remove your instruments, don't panic, form the antechamber well, use other instruments. When you do these cases, such hard cataracts and mature cataracts, you see that your armamentarium, you should have a good microforceps, rexis forceps, and bent Vanna scissors, so that when these things happen, you shouldn't mount panic and slowly proceed further without doing much damage to the endothelium and give a patient good visual acuity. Thank you.
Thank you, sir. Just one question, sir. In the last case, it was a soft cataract. When you were suspecting the rexus tear has gone posteriorly.
Yes.
But if it had been a hard cataract, what would have been your
Hard cataract, if it's more than 4, nuclear grade 4 or 5, it's difficult. In that case, better, because we can't proceed with the phaco further, because you're going to extend the PC rent. So in that case, better convert it into a manual and then proceed. Make incision large, remove the nucleus with the manual method and proceed. It's very difficult once you got a hard grade of 4 or 5. Going with the phacoemulsification, the same method which I did in this case will be difficult. In that case, the nucleus will get dropped into the vitreous.
Thank you, Dr. Chandrikan, the beautiful presentation of rexus tear management with beautiful videos. Now invite Dr. Mridula. Talk on posterior capsule rent management without vitreous loss. Mridula is a director of Trinity Group of Hospitals in Palakkad and Thrissur. She is a well-known phaco surgeon. Over to Dr. Mridula.
Thank you. A warm good morning to all of you, and thank you, Anup and KSOS, for giving me this opportunity. See, PC rent is something that is inevitable for a phaco surgeon. We all know that. The incidence may vary depending on the expertise of the surgeon. There are so many risk factors we notice, like a short neck, obese patient, poor cooperation during the surgery, and even a poorly draped eye with a pooling of BSS can cause a PC rent. Other risk factors include a positive pressure during the surgery, hypermetropic eye, even a myopic eye, small pupil, mature cataract, and something which obscure your fundus glow, like retinal hemorrhages, vitreous hemorrhage, etc. It can happen at any stage of your surgery, like rexus extension, as sir was telling, can cause an Argentinian flag sign. During hydrodissection, especially if you have a small rexus and you try to push in more fluid, it can cause a PC blowout. And again, in some of the cases, you have a corticocapsular adhesions, which can also lead to PC blowout. Nucleus management, again, during a deep trench, if you go very deep, you can rupture the PC. In case of a soft nucleus, if your power, phaco power is more, you can eat up the nucleus and the PC also. A blunt tip used, again, can cause undue pressure on the PC, resulting in a PC rupture. Most of the time, it happens during the removal of the last piece. This case, it was going as smoothly as ever, as predicted, and I was removing the last bit of nucleus, and suddenly there was a surge, and I caught the nucleus. You can see the stretch lines on the PC, and I've ended up in a PC rent. This is what you should not do. Immediately withdraw the phaco tip. You should not do. You should always fill the area with the visco and then only remove the phaco tip. It can happen during an IA, PC polishing, and even during an IOL implantation if it pops out with a jerk. How do you identify a hyaloid face rupture? You can see a sudden deepening of the anterior chamber, a peaking of the pupil, and enhanced red glow. And sometimes what happens is already the nucleus which was rotating, you find it difficult to rotate. And you might notice a nucleus tilt. And if there is a vitreous in the anterior chamber, you will have a poor followability to remove the rest of the fragments. And always, if you have a sponge test, that is with a wet sponge, if you wipe it, you can identify the vitreous in the edge. This case, I was doing the cortex aspiration, and as suddenly I just ruptured the PC. And you can see there's a sudden deepening of the anterior chamber, peaking of the pupil, and enhanced red glow. Now, what you do is push in visco, and you can, with a sponge test, you can see whether the vitreous is there or not. Wet sponge, you just rub it, you can see the movement of the vitreous inside. See, that's what exactly you see. Now, close the main port. That's very important because during a vitrectomy, you should need a closed chamber. And then do a thorough vitrectomy. Notice that always the irrigation port should be parallel to the iris plane. Now, the management basically depends on the timing of the phaco, at what stage you are doing it, location and the rent, of the rent and the size of the rent, and if there is an vitreous disturbance or not. Any stage, whatever it is, push in high molecular weight viscoelastic, lower the bottle height. If you have a higher end machine, you lower the parameters. Your aim should be to clear the nucleus from the anterior chamber. Do a very slow phaco. Any undue manipulations inside the anterior chamber should be avoided. One thing you should notice is that don't try to chop the nucleus into smaller pieces, because that will drop the small pieces into the into the vitreous. Use always a second instrument to support the remaining nucleus, and after the removal of the nucleus, do adequate vitrectomy, and if nothing is working, convert it into an SICS. Anterior vitrectomy, the main goal should be that you should remove the vitreous from the anterior chamber without causing any traction onto the vitreous base, and try to do it in the closed chamber. A bimanual approach is always the better approach because it gives you a more stable anterior chamber, and try to avoid shallowing of the anterior chamber. As and when required, you refill the anterior chamber with visco. Always try to stain the vitreous with a triamcinolone acetate so that you know where the vitreous is. You can easily complete the vitrectomy. Do not hydrate the vitreous. See, the more you try to pull the vitreous, the more it will start coming. It's like a slinky toy. Keep the infusion, as I already mentioned, parallel to the iris plane. Do not use the main port to do the vitrectomy because that causes shallowing of the anterior chamber. Never try to chase the sinking nucleus with a phaco probe. That's dangerous. Now, this case, already I have a PC and there's a small bit of cortex inside the vitreous. I'm trying to remove the cortex. See, one thing is you try to remove the cortex from the area away from the PC rent. That's very important. Why I'm telling you this is, you will notice it at the end of this procedure. See, I'm trying to remove as much as possible the cortex with a sweeping action, tangential. That is very important because it reduces the stress. The minute I touch the other side, the vitreous has come out. Now, stain with anterior vitreous with the triamcinolone acetate. Again, the irrigation is parallel to the iris plane. That's very important because if you dip it down, it will cause hydration of the vitreous. And you see things are quieting down. You can see everything. The pupil is round. Eye is becoming quieter. There's still a small bit of cortex there. After the anterior vitrectomy, you remove the remaining cortex also. Very slow, no undue pressure. And see, that piece also came out. I am removing it with a vitrector. Complete the vitrectomy and then put in a 3-piece IOL. Now, the basic principle of a vitrectomy, if you're a beginner, one thing you should understand, I also always had a confusion whether it's a cut IA or a IA cut. See, what happens is, you should understand, you're going to cut the vitreous and aspirate the cut vitreous. So it's a cut IA. When do you do an IA cut? If you have a lot of cortex in the anterior chamber, you need to aspirate. So IA, irrigation, aspiration, and then cut, IA cut. Cut the aspirated cortex. So the bottle height should be reduced to minimum, that is 30 centimeters. Maximum what your machine offers, the vitrectomy, that you do it. And vacuum lower, 100 to 150. Aspiration flow rate around 10 to 14. One thing is, in your basic foot position 1, it is irrigation, 2 is cutting, and 3 is aspiration. Keep that in mind. So 1 is always irrigation, cutting, and aspiration. So the vitrector port, initially, if you have a vitreous in the anterior chamber, you do it in the horizontal parallel to the iris plane. You cut all the vitreous that is there in the anterior chamber. After that, you go deep, just below the PC rent, and cut the vitreous at that area also with the port facing anteriorly so that you can visualize what you're cutting. Always stain the vitreous if required. And how do you know the end point of vitrectomy? There's fluttering in the anterior chamber, everything quietened down, like you saw in the other case, and pupil becomes round. There's a second approach called a pars plana vitrectomy, which is introduced by David Chang and Abhay Vaswada. And here, what they say is it reduces the risk of enlargement of the rent, and always it reduces the chance of injury to the corneal endothelium and less traction on the vitreous base. So here the irrigation is from the main port, like through the side port. The vitrector is passed through a stab wound that is... Can I show the video? Yeah. So I'll just show this next video. So the cortex is aspirated in the tangential manner. Always fill in the anterior chamber before switching over the hands. And once all the cortex is removed, the lens is placed in the sulcus. I will dialed into the position and just press on the optic so that you get an optic capture. This is the last slide. Here, there's a PC rent, and block the PC rent with the high molecular weight viscoelastic, and using a microforceps, convert that into a posterior capsular rhexis, and you can place the lens in the bag. So these are this is my last slide. Avoid nucleus drop, avoid fragment drop, any damage to the corneal endothelium, prevent enlargement of the tear, prevent damage to the rhexis margin, and all the cortex should be removed, and proper positioning of the IL should be done, making the wound airtight after putting a suture. Thank you.
That was an excellent talk, Dr. Mridula.
Yeah.
Very nice, actually.
Thank you.
Yeah. 2 steps which I would like to recommend to prevent a PC rent. One is keep your side port optimally small. Don't put it, insert your side port slit knife up to the hilt, just optimally small during your emulsification. And once you come to the bimanual IA stage, where you have to introduce your bigger cannula, then you increase the size of the side port a bit more, and so that your anterior chamber will remain stable throughout the procedure.
Yeah,
And
exactly,
second
that is what even I do. I make my second side port very partial entry so that you get a nicely tight wound. And once the cataract is removed, then you can do, so as Sir said, you can extend the side port and then do the bimanual.
And 2 is bring step down phaco. Step down phaco is as you progress in your phaco emulsification, as you come to the 3rd piece or the 4th piece, you bring down the vacuum and flow rate, bring it down to 100, even 90. I even work at 75 for the last piece. Particularly in black cataracts, when I come to the last pieces, I also do one thing. By the time I reach the last piece in a black cataract, your side port would have become really big. And so you put another small side port and proceed with your surgery. Thank you so much, Dr. Mridula.
So thank you, Mridula. So the next talk is by none other than Dr. Jason, a very flamboyant and versatile surgeon. He can do anything in the anterior segment. He'll be speaking to us on posterior capsular rent management with nucleus fragments or the whole nucleus still in situ. Dr. Jason, please.
Thank you, Dr. Anup. I'll be talking about PC rent management with the nucleus or fragment still present in the eye. So when you get a rent with the nucleus or nucleus fragment in the eye, your primary aim is to prevent enlargement of the tear. And vitreous, you should prevent vitreous prolapse. And of course, you should prevent nucleus drop. So the strategy will be you have to maintain anterior chamber from collapsing, bring the fragment to anterior chamber, and trap the fragments with the viscoelastic, and do bimanual vitrectomy. And finally, you have to remove fragments safely. So you can see in this video, it's a posterior polar cataract being emulsified. and everything is going fine. But when I remove the second fragment, so when I removed the second fragment, I suspected a rent. So when you get a rent, what we have to do is, don't withdraw the handpiece. That is the first reflex you might get, but don't do that. And keep the pedal in position 1 so that there is irrigation. So that means you have to stop emulsification, you have to stop aspirating, and keep it in irrigation mode. And through the paracentesis, you inject viscoelastic to maintain the chamber. You can see the rent there at the center, and through paracentesis, I am injecting viscoelastic. This is a stressful situation you can see on my left hand. And then you have to form the AC before you withdraw the handpiece. What is next? Next is you have to bring the fragment into the anterior chamber and trap it with the viscoelastic for emulsification. So how do you do that? The hurdle will be sometimes the small rhexis, as in this case. Sometimes it will be pupil. So you have to enlarge your rhexis, maybe double rhexis. But in this case, I have done, this is not a recommended technique, but I have done with the phaco handpiece. The issue with the handpiece is it will irrigate. That will hydrate vitreous, and more vitreous will come into the AC. So this case it was done with the handpiece, and use viscoelastic and inject viscoelastic through the PC so that you are creating a barrier between the vitreous and the anterior chamber. And the vitreous should protect the endothelium also for emulsifying. Next step is lens emulsification in the anterior chamber. You have to understand that the emulsification is happening in the anterior chamber, so you have to really protect your endothelium, and you have to plug the capsular opening with viscoelastic. Reduce bottle height, and all parameters should be reduced. Bottle height is reduced because bottle height can push the nucleus down, and flow rate is reduced because you need a slow motion phaco in this case, and vacuum is reduced to reduce surge, post-occlusion surge. And if vitreous comes, immediately you have to do vitrectomy, you have to stop it there, and vitrectomy should be done. The cortex aspiration part and the anterior vitrectomy part I am skipping because Dr. Mridula has already explained these steps. And IOL selection part, I don't know whether she has mentioned. Anyway, I will talk on that. If you have an intercapsular rim, you can implant a 3-piece IOL. The optic capture can be done. The haptic is in the sulcus, and optic can be in the capsular capturing can be done, as in this case. And aspirate all viscoelastic. If possible, viscoelastic beneath the IOL also should be washed, because that will reduce postoperative rise in IOP. And this is how optic capture is done. Once that is done, IOL is more stable. All tags of vitreous should be removed. You can use the triamcinolone for that. And suture all these wounds, because when you do vitrectomy, there is a chance of postoperative hypertony. So suture those wounds to prevent wound leakage. The chance of infection is high in these cases, so don't give any chance for infection. We'll move on to the next scenario where you have a nucleus in the anterior vitreous phase. So when you have a nucleus in the anterior vitreous phase, don't try to aspirate the phaco tip, because the infusion is going to push the lens nucleus further away. And you are likely to aspirate vitreous, and that can cause traction, and you can get a giant retinal tear. How you bring the nucleus into the anterior chamber? It may be difficult when you have a small rhexis or a small pupil, but this should be done through pars plana. Approach through pars plana is easier than approach through paracentesis, and you can see in the video the posterior assisted levitation of the nucleus being done. And since it is a large nucleus, now I don't think we can emulsify, so it is removed using a small incision technique. And viscoat levitation is much more refined than this technique. I don't have a video for that. Next comes posterior capsular rhexis. That is another thing you can do when you have a retained nucleus fragment in the back. So you can do this rhexis for small PC rents only. If it is away from the equator, if it is in the equator, you cannot do this technique. If you have a tag, you catch hold of the tag and it is moved circumferentially to get a complete rhexis. See, if you get a complete rhexis, posterior capsular rhexis, your advantage is your capsular bag is strong. It will not extend while emulsification or while aspirating the cortex. And finally, you can implant a lens in the back. Even cortex aspiration is easy because the bag will get inflated. You can easily approach the cortex. And finally, some of you might be thinking going through pars plana is difficult for an anterior segment surgeon. If you are hesitant, what you can do is you can do the same technique through using two paracentesis. But you have to take two Shinseki hook, and this is the case of small people also. With the bimanual technique, you are more used to paracentesis, so it is easy for us to handle the nucleus fragment through paracentesis. So strategies to prevent lens material drop includes prevent AC collapsing, bring the fragment into the anterior chamber and trap with the OVD. And bimanual vitrectomy is done whenever it is required. And finally, fragment removal either with emulsification or manually. Thank you.
Thank you, Jason. So your videos are self-explanatory actually. I have nothing much to add on that. Only thing, probably the viscoelastic that you said, you meant of course dispersive viscoelastic, isn't it? So that is only what will...
Yeah, viscoelastic, I think cohesive viscoelastic has no role in handling this. Maybe for IOL implantation you can use it.
Okay. So thank you, Dr. Jason. The next I invite Dr. Jay Prasad. He's a very senior surgeon, MD of Amardeepai Hospital, Kollam and Trivandrum. He will be speaking to us on managing zonular dialysis during phaco. Till JP's slide is getting ready, it's ready? Okay, thank you.
Good morning, all of you. At the outset, let me thank Dr. Anup for this opportunity. All these years, I have never spoken on a stage in relation to zonulopathy and PC rents, because I feel people should not know my complications. And but then Anup said you should show your issues. So zonulopathy is the topic for the next 10 minutes. Let me take you through this video. Hypermature cataract, small people. This is about 5 years back. So hooked with iris hooks, rhexis, chop, direct chop, vertical chop, bimanual rotation always. So I'm doing that, separating very carefully. There is hardly any cortex or epinucleus left. Emulsified slowly, and as I come to the last, I am coming down to 70 vacuum, and here the capsule is at the phaco tip. Anup, how will you proceed from here? Anup?
It's a very tricky situation because the capsule is entangled into the phaco probe. So one thing is you have to bring it to foot pedal position 1, irrigation mode only. And then with your left hand instrument, slowly try to tease out the phaco flap from the phaco the probe. And if you are able to do that, then inject viscoelastic from the side port.
Right, thank you. So we'll see what happens to it at the end of this talk. When you are planning cataract surgery in any patient, get a good history of trauma, yes or no. Look at the position of the lens under slit lamp. Look for visible zonules, a shallow anterior chamber in a normal axial length, an irregular anterior chamber depth, donosis of the lens or the iris, the presence of subtle vitreous in the anterior chamber, and intraoperative signs like when you are trying to poke on the anterior capsule, it's not getting poked. When you are moving it, the entire lens is moving. Or once the bag is empty and then you see there are horizontal tangential wrinkles in the posterior capsule, all indicating that the zonules are weak. The 140, 180 zonules in each eye, at least some are weak. So whenever you address zonulopathy, you look at its extent. Is it less than 4 clock hours? Or is it up to 50%? Or is it really severe? And you also look at as to whether the zonulopathy is progressive or not, like in pseudoexfoliation syndrome, where the disease continues its course over the lifetime of the patient. And of course, you have associated complications like associated issues like small pupil and vitreous in the anterior chamber. If you have a small zonulor dialysis like this, at the end of the last bit of cortex aspiration, I'm pulling the capsule in. The small ones, you can leave it alone. Keep the lens in the axis of that dialysis. That is all that you need. It is all the more better if you can keep a 3-piece IOL in the bag in that axis. But I generally prefer to implant a CTR even if the zonular dialysis is small. So you can see that is a replay, and all these videos are running at 160% speed. So you go in there and implant a lens into the bag in the same axis. Supports for more severe cases, the capsule support intraoperative, and the iris hooks can also be used. The iris hooks, remember, will only hold the anterior capsule, where the capsule hooks will hold not only the anterior capsule, but it will also hold the equator. It's much better to use a capsular hook. So there are 3 varieties which you use depending upon the type of zonulopathy. We'll start with one eye with 3 clock hours of zonular weakness. Remember that when you are doing your rexis, you will see, because this is running at very high speed, you will see that the lens is dangling. It's more in the zonular weakness was more in the subincisional area. I'm sitting on the temporal side. Found it little difficult to go through that area. And once that is completed, chopping should always be direct. You don't trench usually in these eyes, except a small subincisional trench that I used to do. Support with iris hooks is what I have done in this particular patient. And when you are introducing your phaco, remember always low flow, low vacuum phaco. Hold, do a vertical chop down there, rotate bimanually so that you don't transmit. Iatrogenic issues are the ones that create more problems for you. And once you come to the last piece, always bring down your vacuum. Bring down your vacuum, down, down, and down. And then you can implant a lens. I prefer to implant the lens after implanting the CTR. CTR is usually implanted through the side ports. I prefer to go through the main wound. The main disadvantage is if you have a longer main wound, it will be difficult to introduce the leading eyelet into the bag. And when you go in, always have a second instrument in your left hand. A Sinski's hook is all that you need. I generally take out the iris hooks only after implanting the CTR and the lens. Then implanting the IOL is no issue. This lens will remain there, very strongly supported. When you have trauma, generalized weakness, plus one small area which is more damaged, and you are not able to continue with your rexis, you can use a side port instrument, a 25 gauge forceps, or I am using a dialer actually, to support the already made rexis and then proceed with your rexis. So this is one step you can do. You can use a V-hook also to support. Ideally is to catch that with a 25 gauge forceps and continue. Support the lens as you proceed with your rexis. So once the rexis is over, this is an intraoperative tool, and then you put in the hooks, hydrodissected, and at hydrodissection I have seen vitreous coming out, stained with tricot, triamcinolone, 10 milligram per ml, 10 times diluted, hooked with capsule hooks here, and then vertical chop, bimanual rotation, step down phaco, and then I am using a Sione ring with an eyelet to put in a suture, 90 suture, that is what I used to use, and then clamp it to the sclera. So anchor to the sclera here, and then you implant your lens. A 3-piece lens goes in. More traumatic subluxation, large area. Some of these traumatic cases may remain still even without a CTR. That is what I have found. If it is very small, over years, it doesn't move that much. But always when you have such a large one, more than 4 clock hours, it's always best to anchor using a Sionis ring or a Ahmed CT segment. So once you come to the end of this, always remember to hold with your capsule hooks, not too tight, because when you inflate the anterior chamber or when you get the irrigation in, the AC suddenly deepens and it can tear the anterior capsule. It has happened to me multiple times. The wound has to be increased a little bit more to get that eyelet inside, not like your regular CTR. And once it is inside, then it is easy. You can gently dial it and then bring it to the position where you want to anchor it. In pseudo-exfoliation, my strategy is, in mild to moderate sonilopathy in pseudo-exfoliation, I always, after cataract surgery with support, I introduce a CTR, and then I put in a 3-piece IOL into the sulcus and get an optic capture. And then I put a small hole in the periphery, which I call as a peripheral anterior capsulotomy, to prevent a capsular distension syndrome. This is after surgery, lens in the sulcus, and then I push down the optic after taking out all the OVD from behind with a low parameters from the back, because remember that it is pseudo-exfoliation and the posterior capsule is very lax. So you get this sort of a, this shaped, oval-shaped capsule. And if you notice, I have put small nicks at the edge of the rexis to prevent a phimosis. This is another case of pseudo-exfoliation. I have used the iris hooks to get the capsule also supported along with the pupil. And once the emulsification is over, I hook back only the iris now, release the iris hooks, and then hook back the iris. And then I go in and implant a 3-piece lens. I use the sensor, I have no commercial interest. And once that lens is in position, it has 5-degree angulation, still we can push the optic, gently nudge the optic into the bag, and then I go in and put a peripheral anterior capsulotomy with a very sharp, fresh 26 gauge capsulotomy needle. So lift up the iris and then put a small nick there, a small opening that definitely prevents capsular distension syndrome. In a 55-year-old with pseudo-exfoliation and no sonular weakness, I still feel we should put in a sulcus fixated lens with optic capture, because this guy has to live for a long time. In contrast, at 75 or 80 years with no sonula weakness, I'll definitely put in a CTR, but with an in-the-bag IOL. And when you have severe sonulopathy, I prefer iris fixation with 9-0 sutures or an iris glow lens. And finally, I have only put one implant of an AC IOL all these years in a pseudo-exfoliation, 98-year-old man with good endothelial count. We're dangling lens, and I was able to get a rhexis, but then I didn't want to proceed with phaco. I cut it open multiple areas with a 25 gauge scissors, then injected, did a general hydrodissection, injected OVD underneath, and then put in a vectis behind with continuous flow of visco. It was gently eased out of the bag and out of the eye, and the wound was reduced in size, and an AC lens was implanted after ensuring that there was no vitreous in this eye. Pupil was constricted with pilocarpine, and then an anterior chamber lens was implanted into this. The patient is now 99 and a half years old now, still kicking well. And before I go, let me show you the first case that I showed, Anup. So I went in, as you said, correctly said, dispersive OVD here, going in. Press on your reflex switch. Always remember, so that it will come out of this. And then once you fill that clear area where the vitreous is exposed with a dispersive OVD, that acts as a barrage. And once that is done and the bag has left the phaco tip, you gently come out here. You are coming out, and then you go in with your cohesive OVD, go into the bag, inject, the bag opens up very nicely, beautiful, very deep, and into its normal contour. Then I introduced a CTR, a capsular tension ring, from the stronger side first, then to the weaker side. In there, tamponade once again with OVD on the other side, and completed my phacoemulsification. And once that is done, then it is very easy to implant a single piece lens into the bag. This patient had 6/9 vision at the end of 1 week, 6/9 unaided vision at the end of 1 week. I was extremely happy, and let me tell you that the capsule, the CTR or the lens, they do not know that Dr. JP has operated, and they should be sitting there. 2 years down the line, they fell down. The moral of the story, let me tell you, dear friends, is that if you have severe sonular loss, always anchor. Don't try the smaller step, always be on the upper step, the higher step. And with that, let me conclude. Minimum surgical trauma, maintaining anterior chamber throughout the procedure, a careful preoperative evaluation, and judicious use of supportive devices, always erring on the higher side, is extremely crucial in managing sonulopathy. Thank you very much.
Thank you, Jayaprasad, for that wonderful presentation. Over to J.K. Reddy, sir. He doesn't need any introduction at all. He's one among us. Over to you, sir, for the next topic.
Good morning, and I thank Dr. Anup and KSOS for this opportunity. Now you saw all the problems, complications right from the beginning. There are too many things, when you show like that, it's not good. I feel for junior, especially people who are starting and postgraduate, it's not good to do so many complications. So you'll be a little hesitant when they touch the surgery. They will first see all this what we have shown. So they say mind will not work. All this will be running like a cinema in front of the movie. So when nothing works, what you will do is, so when all these techniques which the speakers they tried, or we cannot try also sometimes. So no capsular support. This is not posterior capsule, no capsular support, because posterior capsule, the anterior capsule is there. We can put the lens inside happily in the sulcus. So my talk is no capsular support. What will do it? So there's two things, planned and unplanned. Whether pre-operatively itself there is no capsular support, or accidentally. First one is easy. Already we explained to the patient, you have a problem, you have a complication, everybody has told, so you have this problem, so I will try, what will happen, let us see. But second one is the problem. unplanned. We didn't plan it during surgery, but it happened. We assured a patient very good results, and we had to do resurgery. That is the main problem. Second is, so these are the pre-operative things which we explain to the patient. So you have no capsular support. We have to do a different technique, and I will manage somehow. So what are the choices available? We have, one is the angle supported lenses, and iris supported, and scleral supported. So these are the only three areas right now available for the intraocular lens. Cornea we can use for keratophakia, but we cannot put a IOL in the cornea. So the coming to the Kalman, same Kalman which we are doing the phacoemulsification, who developed, he developed multiflux IOL. He called it a lens for all seasons. But somehow it proved to be, it's very difficult to give a long-term vision with this lens. The complications are rate very high. So I think most of the people, almost for 15 years, nobody is implanting these lenses in the antechamber. So people will forget, and most of the juniors, they are not seeing implantation also. So this should be almost for it's a history. Then coming to the iris. So iris, we have two. One is anterior side and posterior side. Anterior side, again, there is a movement of the lens endothelial cell loss. So we are doing to the posterior side implantation. They look basically nice because iris is a very tough tissue. It's the last tissue to undergo degradation after death. So this is a very simple technique. The lens is just, the haptics are pushed onto the posterior side, and no capsular support, either accidental or it is a planned one. So a lot of my friends, they said it's a blind technique. There is nothing blind. We are seeing through the microscope and camera, everything is clearly visible. So a lot of people, they say it's a blind technique, how we can do it. It's nothing blind here. We are seeing, and patient is also seeing, especially when you are doing topical anesthesia. It's a very simple technique, and it gives very good result. It's a very good for unplanned surgery. So see, you are doing phacoemulsification, suddenly you lost the capsule and everything gone unexpectedly or undiagnosed. So you can, on topical anesthesia also, you can finish it, and it's a very good surgery for that. And post-operative results are quite good, except for in almost 30% of cases you get a oval pupil. That is the main problem. Then it comes to scleral supported. We have three choices, where the suturing and entangled or glued IOL and embedded. The embedded one is the one is becoming popular now, and that is the new kid now. The suturing technique, first we started using tanvoprolene. They used to drop after 5 to 6 years after surgery. So then we went for 9-voprolene. So another 2 years after they are dropping. That means 8 years, 9 years after surgery. So now the choice is 6-vo Gore-Tex. It looks very thicky and very messy. So I am not showing those videos because they look very messy, and they doesn't look like something can be done on the eye. So though we did it, so I am skipping, and we have 2-point, 4-point fixation. And this next technique is the scleral embedded or glued IOL. So this is a very nice technique, but it's also a little bit messy. You need it's a better done by a posterior segment surgeon with a infusion through the sclera than from the anterior segment surgeon. So you make 2 scleral flops, and you put the lens haptics through tunnels and fix it. There is no suturing here, so there is no drop. The new one in the kid is the M&A technique. So this is very nice. It looks like though this is a posterior segment done through the by pars plana vitrectomy. So this is a foldable IOL 3-piece lens. You should have a PMMA haptics and silicon or a hydrophobic optic. So this 26G needle is passed transconjunctival. It looks very elegant. There is no need to cut conjunctiva, no need to do scleral pockets and all the mess. So you railroad the haptic with max grip forceps and pull it out. And when you pull it out, you have to hold it. So this is the best part of it is we can do it through a 3 millimeters. And the tip is you apply a heat cartridge. There's a low heat. It's not very high heat. So it becomes a bulbous. So it will get entangled in the sclera. It won't go, it won't slip. So the other side is repeated in the same way. But it has to be done before a thorough vitrectomy. You cannot do without a vitrectomy because the lens movement is there. So you have to do a little bit anterior vitrectomy and then do it. So you don't cut conjunctiva, you don't do anything, just apply heat cartridge and pass it to the. It looks very nice, and it's a very elegant technique. It looks, but once we started doing, We had it post-operatively also looks very nice. And we had the problems of tilt. So when we started more cases, more people across the world, there are a lot of cases, there is a lens tilt. So they developed a complex instruments to prevent that tilt. You have to put that instrument past the needle. So this also is becoming a little not very favorable technique for easy surgery. Then this is the new one from the Italy. So it's a hydrophilic acrylic material. You have two hooks here, which you pass through the sclera and you pull it. And our own Dr. Nivian from Chennai, he is developed with Upsam Associates, another CMT Flex, same type of hydrophilic IOL. You have two hooks on both sides, and you have to make a tunnel, just like in scleral fixation lesson, and pull it and do it. The history has a bad habit of repeating itself. So young people will not see in ACIOLs or something like that. There is ACIOLs are making a small resurgence. So what we found from searching the literature, everything is hydrophilic material looks like a very good material for ACIOL, which we use for ICL, phakic IOL, and so far nobody tried that for ACIOLs. So somebody like me, some stupid, will start and make these lenses, and I think young people will start using them instead of using scleral fixations, all the messy ones, and it's very easy. On the table, we don't need to worry about that. Even you have a phaco and PC problem, you can just put it. Thank you very much.
Thank you, Dr. JK. Yeah, a lot of very new things that we have learned now. Especially, I never heard about those lenses with the hooks, the CMT Flex and all. They are using it regularly? Okay. That's good actually. I mean, a lot of innovations happening so that, initially we had the ACIOL and then we had the iris claw lens, then the glued lenses, now back to ACIOLs. So it's all going round and round, I think. So thank you, JK. Mridula wants to ask something.
Yeah, I have a doubt. In iris claw lenses, do you really need to put an PI?
Yes, 100%. That depends upon the lens. This particular lens, different companies make it. You have a posterior, if there is a vault in the lens, and if you put posterior vaulting, and that means vault means if your lens is curved like that, and if you put a posteriorly vaulted, then maybe you can not do PI. But right now what I am using is from it's a planar lens. You can put either side. So 100% you have to do PI. So we tried initially sometime, one or two cases we tried without doing PI, 100% people deploy.
And how do you disenclave iris claw lens? Anyway,
it's not very easy. We did 2 or 3 cases because not many cases. We did 2 or 3 cases because the lens is not very well centered. Then we disenclaved and re-enclaved the same lens. It's not very easy, very difficult. It's like you have to imagine this like a clip, you have to hold with a vitreoretinal forceps 23G or 20G vitreoretinal forceps one, and just you see on a dimple on the iris, you press on the haptic and you push it, it will get disengaged. Yes, sir.
Okay, one of the videos, scleral fixation, you are pulling the lens with a needle.
Yeah, heating.
It will follow the needle, how it is coming, that haptics is coming along with the needle.
Yes, sir, railroad technique. You put a 27G they recommend, but 27G is not easily available in India. So we are using 26G needle, and through the needle you pass the haptic, with the friction it will hold, and you pull the needle. The trick here is the needle should pass parallel to the in a parallel plane at right angles. That's very, very difficult because the eye is vitrectomized and it is very soft. So in a soft eye, when you are passing, that eye becomes the sclera dimples, and it won't form a very parallel track. It forms a little bit oblique track. So when you pull it back and do it, everything looks very nice, but there will be a lot of tilt. Patient will be having 5-6 diopters astigmatism and uncorrectable refractive error.
You are melting the tip of the haptics. Then
Yeah, tip of the haptic, just heat it, sir. That there is a low heat cartridge there.
heat cartridge.
Just it becomes bulbous, then push it through the conjunctiva. In the track, it will go. Very nice, it will stay.
It will not slip away. It will
No,
not,
no, sir.
Forms a bulb.
bulging there.
Yeah.
So I would like to take this opportunity to thank all the faculty. All of them had excellent videos. Very nice, actually, such beautiful, clear videos. Just seeing those videos, you can learn so much thing. And one thing about JP I would just like to add was he is a person who keeps innovating. So a lot of new techniques he will come up with. He won't follow the, the chosen path. He will keep thinking laterally. Like one tip he said was to make a small capsulotomy in the periphery to prevent capsular distension. I don't think that is mentioned anywhere. It is his own innovation. So that is, I think, one thing that we have to learn from such people is we have to keep thinking out of the box. So with this, we come to the end of this instruction course, and I would like all the speakers I would like to give the certificates. Yeah. I request Dr. Chandrakant sir to please hand over the certificate and memento to our guest faculty, Dr. J.K. Reddy. I request Andreas sir to please give the certificates to the other faculty. Is that? Okay. Fine. Right. Thank you. So one photo.